Hey everybody. So today we'll be continuing with our topic meningitis that we had learned in the last video, and today we are going to talk about viral encephalitis. Now this is encephalitis means what comes in our mind is the seizures. So what is the causative organism? So it is the herpes simplex virus, which is important, and it has been seen that there are two types of herpes simplex. First is the one which is more than that of 3 months of the age group, and in adults it's seen. And if it is two, then it is less than that of the 3 months of the age group it is seen. Now, we can say that it is the most common cause of fatal sporadic encephalitis. Okay, and 90% of the them have been associated with HSV1, the encephalitis part, and HSV1 corresponds to meningoencephalitis. Okay, and HSV2 is also known as neonatal meningoencephalitis because it is seen in less than 3 months of the age. Now, HSV1 is something which affects the temporofrontal part. This is very important, and we will see that the pathology remains over there. And when we see the MRI, we are going to focus about temporal and frontal lobe. Now it is the HSV2 which is involving global. Okay, so anything can be involved. So most common epidemic cause for viral encephalitis as per is the arbovirus, that is the Japanese encephalitis. Coming to the pathology, it is same as that of the meningoencephalitis. That is the through the airway we get the infection, air droplets, or say because of the airborne infection, like airway is the one which is carrying the pathogen, and then it reaches the pharynx, and from the pharynx it migrates to the neurons. Okay, so this is the same pathology as that of the meningitis. Now what happens is through the airways we see that there is this nasopharynx, and through which the olfactory and the trigeminal nerve is the one which is involved. That's why we can say that there are certain neuralgias also that is associated. So we'll see about it later on. Okay, so they can remain dormant, okay, for many months and then cause the disease. Otherwise there could be also reactivation. Okay, so we coming to the clinical features. The first clinical feature is the headache, okay, and fever, along with the altered sensorium, okay, and there would be seizures. There could be mental altered mentation, and there could be also a memory impairment. Along with that, there could be behavioral changes also. And if it is a temporal lobe and the lateral and medial part, so accordingly there could be pathologies. And if we say the lateral and temporal and the medial temporal is involved, you need to see if it is symmetrical or asymmetrical. Now this is the point which is very important to differentiate from autoimmune encephalitis. Okay, so it is seen that in autoimmune encephalitis only the medial temporal lobe is involved. Okay, and that is actually a symmetrical part. Now the symmetry is very important, remember that. Now when we come to the investigations, what investigation you have to perform? Now first is the CSF, that will be performing, right, like that of the meningitis we have seen. So there would be lymphocytes which will be predominant, RBCs would be there, there could be xanthochromia, there could be sugar which can be normal, right? In viral part we have seen that the sugars are normal. Now PCR could be done if we are suspecting HSV. In our institute we see biofire, okay, so that all the pathogenic organisms we are aware of it. Okay, now the other thing, that is the ideal time for that of the HSV PCR is almost like 8 to 10 days is the ideal time. Antibody HSV could be done, that is 10 from the 10 days to that of the 14 days. Okay, so that can also be performed. Then CSF antigens, so it is less specificity and sensitivity as compared to that of the PCR, but yeah, that can be also performed, but it is not usually performed, right? Now, when we see the MRI, there is a T1, T2, and diffusion weighted imaging that should be seen. In the T1, we just see the lateral and the medial part, which is asymmetrically involved, that is mostly seen, right? And it is asymmetrical, right? And the insula, okay, that should be also visualized. gyral edema is there, and hemorrhage could be there, depending upon if there is vasculitis or there is any other intracranial hemorrhage like that. So you have to see that. If we come to the T2 part, there could be a contrast enhancement, there could be actually a gyral enhancement, or leptomeningeal enhancement, or a ring enhancement, or a diffuse enhancement. Okay, so there is enhancement which is seen in the T2 part. Okay, so these are certain MRI findings. Okay, um, so yeah, so the arrow marks denote that there is certain infection and there is an enhancement which is mostly in the T2 part, right? Now, NMD encephalitis, as I said, that there can be actually one of the trigger, the HSP can act as a trigger for the NMDA encephalitis. Now, if you see the imaging, of course, there should be symmetrical involvement in case of NMDA encephalitis, that is an autoimmune encephalitis. But if you see there is an asymmetrical involvement, that is mostly we have to refer to as a HSP encephalitis. Either ways, we are going to give a cocktail, right? Of zone, vanco, cyclovir that we are giving in our institute. But this should be the overall your how to notice a disease and what is the pathogenic organism. Okay, so whatever we are doing, that is okay, fine, we are doing as per our institute and whatever is available at our institute. But yeah, but remember that the pathogenic organism, knowing it and in detail knowing the pathogenesis about it and how does it actually present to us, so it is very important for us in the vivas and all, they would be asking this. Okay, so if you see, there is EEG also we will be doing because there will be seizures, right? So in the EEG, there are certain characteristic things like there will be a spike and wave localization to the temporal lobe. There will be periodic lateral epileptiform discharges, okay? Focal and generalized slowing, and there could be also or electrophysiological seizures, okay? So if we treat the patient, so even if we treat the patient, the mortality is almost like 30%. So remember this, this is very important. Okay, so how do we treat the patient? So first of all, supportive management could be given. Okay, then anti-epileptics are to be given. When we give the antiviral, we have to give a cyclovir. That is the first choice for her. And if it is given for 14 to 21 days, how is it given? It is given IV 10 milligram per kg 8 hourly. Now remember, if we give the bolus, then there could be a chance that there would be an amorphous material that can be precipitated and cause obstructive uropathy, as well as in the renal tubes there could be precipitation. So a slow infusion is always preferred. Okay, and obviously IV fluids have to be given. Now in case if you do not have a cyclovir, you can also try with foscarnet. Okay, anti-epileptic has to be continued even after 1 year of the we have stopped the treatment. Now, when we talk about the HSV, we have to also think of varicella zoster also. Okay, so varicella zoster can cause primarily of meningoencephalitis or myelitis. Okay, uh, acute cerebellar syndrome, acute demyelination. So these are the things that is a primary infection, but it can also cause reactivation. So, how does a reactivation occur? So, there could be meningitis, encephalitis, radiculitis, cerebellitis, or Ramsay Hunt, and neuralgias, neuropathies, okay, and stroke, vasculitis. So, these are the things. Now, if we talk about herpes neuralgia, so there could be an acute, subacute, or a post-herpetic neuralgia. Okay, depending upon the time period. So, time period is less than 1 month, 1 month to 4 months, and more than that of the 4 months. And if we talk about zoster sign herpety, that is actually a pain is there, but the lesions are not present. Okay, so here the patient would be complaining that there was certain amount of the pain, but there is no lesion. You cannot see any lesion. Okay, but there is history that patient has suffered HSV infection, varicella zoster infection in the past. Now, there could be zoster ophthalmicus, which can involve ophthalmoplegia, then retinal detachment, retinal necrosis, iritis, scleritis, okay, and keratitis, uveitis. So, they can also be there. Along with that, stroke and vasculitis is also seen. When we say about Ramsay-Hunt syndrome, there could be a seventh nerve which is mostly involved, and there could be also eighth nerve that can be involved. Okay. Otherwise, there could be also lesions which will be present on the palate, on the tongue, on the external part of the ear. So this is the Ramsay-Hunt syndrome. And now this is very important. It can also be called as Zuster oticus, right? Now, varicella zoster vasculitis. Now, vasculitis means it is stroke, okay? But it can also involve the acute stroke with recent infection. There could be a spinal cord infarction. There could be the our intracranial hemorrhage. Then there could be subarachnoid hemorrhage, aneurysm, dissection. So of course there will be contrast enhancement on the MRI. Then on the MR angiography, there could be bleeding. There could be actually aneurysms which would be visible. Okay, so that is the thing. Now in this also, a cyclovir is given, that is 800 milligram per oral, that is 5 per day for 7 days, and valacyclovir 1 gram for 7 days. Okay, this is actually optional, cyclovir or valacyclovir. Now, in case of the zoster encephalitis, remember 10 to 12 milligram per kg 8 hourly for 21 days. And in case of a vasculitis, we give acyclovir 14 to 21 days with steroids. And in post-herpetic, as there will be pain, much of the pain, so there should be opioids, analgesias, and topical analgesics, anticonvulsants should be paired with along with the acyclovir per oral. Okay, so that's all for today. Thank you for watching.